everybody. Welcome to Ask the Anabolic Doc, starring Dr. Thomas O'Connor, brought to you by his websites, anabolicdoc.com and metabolicdoc.com, where you can get his new book, America on Steroids, A Time to Heal. Welcome, Doctor. Welcome. How are you, sir?
Thank you very much, Ron. Very happy to be here once again.
Yeah, busy week. It's the Arnold week. Are you going to the Arnold this year, Doctor?
God, you know what? Definitely not this year because we're opening up the office in Florida, so we have to get down there and we got to work on the details because we got to open that place in Florida. Sometime by mid-April, the end of April, we'll be seeing patients in Florida.
Wow, that's quick turnaround.
Yep.
Okay. So we had some questions from the forum, but I wanted to start questions that you've been, obviously people hit you up on your own social media and website. So you had a couple interesting questions from fans and people that want some information. So let's hear that.
Yeah, thank you very much. So, and it's kind of the same stuff I do over and over is the steroids, how it relates to heart disease. So this was a question on one of my videos. It was the beta blocker, and it was the video I put out 2 videos back about beta blockers and heart disease with steroids.
Okay.
So the question was, a man said that he was using steroids, insulin, and growth hormone. He had a reduction of what's called his ejection fraction, which would be like heart failure. And he had a condition called left ventricular hypertrophy, LVH, which this is all the stuff. You see, it gets kind of boring here, Ron. It's all the stuff I talk about. That's the heart word. Yeah. So that's the heart thick. That's the meat of the heart, which gets enlarged by just age and just having regular disease as you get older, hypertension, and then the other one I talk about is the heart artery, which is called coronary artery disease. They're actually very different processes, but of course it's both the heart. So this man was a steroid user and growth hormone and insulin, and he had a reduction in his ejection fraction. He was kind of young, I think 30s or 40s, and a doctor diagnosed that. I assume he presented to his doctor feeling very tired. I don't think he had a heart attack at this point, but he felt sluggish, malaise, and fatigue. So he did, which is in my video I talked about, and again, it's all a lot of disclaimers, Ron. There's no, I'm never do this, but we're talking, and I'm not going to work with Tony Huge anymore. I'm kind of like you, Ron. Like, I try stuff.
Yeah.
The guy got, if Tony's watching, I don't know, there's a lot of hatred out there, and haters are going to hate, haters going to hate. It's just half the stuff's for you, Ron, because it's like our show. We go by the gut, right, Ron? You go by the gut. Come on, people. We're trying to do this because we're trying to help. You've been doing this a long time. What you do is a fitness expert, media guy. I'm a doc. I've been involved with my foot in the world of the bodybuilding, steroid using world, which I'm trying to help. So when I put videos out, it's disclaimered like crazy. I'm not saying that I did it to anyone. I'm not sharing names. And Tony Huge obviously is a pretty wild and crazy guy.
Yes.
And it's like, but he's obviously a smart guy as far as his cerebral abilities.
Right.
Now, what he's doing to himself and the steroids and all the stuff he openly does, look, it's none of my business, and I don't want to give a blessing on that, but he does ask some really cerebral questions, like, hey, Doc, if a person's going to have heart disease on steroids, how do you protect against it?
Yeah, that's a good question.
That's a good ethical question. I don't give a blessing on steroids. Ron, you don't.
Right.
But if people are going to use steroids, if people are going to use heroin, we give them methadone so they don't suffer and they don't die.
And give them clean. We give them fresh needles so they don't share needles.
This is it's called being progressive.
Yeah.
So this is just what it is. It doesn't mean we agree with heroin. We look at the realities of how do we limit the hurt? How do we limit disease? So that's an example. So with this video, I had to clear that up. Incredible. The response is always incredible. you know, I guess they're my fans, they're my supporters.
Yeah.
There's always some hatred on there. Like, you know, we're trying, are we really furthering and get the use of steroids, Ron? I don't always, I just have to always come up with the, you know, what are we doing this for? Oh, okay. So Tony asked a question, Doc, can we use, and I've been talking about this for years, can we use medicines to prevent disease while you're on medicines that frankly people are going to use against my recommendation?
Right.
And the truth is, let's talk about beta blockers. So getting back, so this man actually did, he has a low ejection fraction, which is he has heart failure. He has diastolic, at least diastolic, and this is systolic dysfunction. His heart's not fully functioning properly. That's a problem. So we know from disease protocols and from standards of care, we can use beta blockers for people that have heart failure.
Yeah.
That's what I'm talking about, the early use. And I'm more interested in, can these work? What are the mechanisms? How do they work? So you have to understand the medicine and physiology, cardiovascular physiology. So this man shared that he used cardavolol. And that's a different type of drug, and it helped him, and apparently in the end, I don't remember the exact question. We're moving so fast here in our daily lives. It seemed like it helped him. It's another type of drug similar to Bistolic that everyone knows I like that. Bistolic is it's a non-cardioselective beta blocker. It's used in America for hypertension. In Europe, it's used to actually modulate for LVH and for dysfunction of the heart early and even late, but not for here, not in America. It wasn't cleared for that. It's cleared only for hypertension. So, and this is very complicated, detailed medical stuff. And I like it because it's a nitric oxide donate. So it increases nitric oxide. What's the other drug that increases nitric oxide? Cialis and Viagra.
Yeah, we just talked about that.
If you use these drugs with men that have a host of medical issues with hypertension, maybe they have a decrease in their ejection fraction, early heart failure, which I see all the time, Ron. It's great to use these because they tolerate it better than, say, metoprolol, which is a cardioselective beta blocker. Very complicated. So this man and so I said to him, the mechanism of action is very interesting, and we don't fully understand. But it's true, though, that one of these two drugs, cardavolol, bisoprolol, and Bistolic, you know, novibolol, these are incredible meds that are for use properly. This could help thousands and millions of people. They can get, first of all, they should be on medicine from a cardiologist or a good internist, but they can get off some of the more aggressive and crude medicine, and they could use these and this really helped the guy. So the other question was, so that's the answer to that question, that it's interesting. We don't know. They're cardioselective. Some are non-cardioselective. They modulate the heart rate. They allow the heart to fully fill. They allow the heart to relax better and therefore fill more, and they pump more. It also protects against what's called there's a neuroendocrine side with the body when men get, and people, women too, of course, in different stages of heart failure, they start getting what's called neuroendocrine aspects, and that's why we add other types of diuretics, and we're trying to slow down the train. So the heart rate is a big thing. So the next amazing question was, Doc, can we use this beta blocker to improve and increase your cardiac output? For an example, modulating maximal and submaximal heart rates. Now, this is cool stuff, and that's why it's probably on the IOC list as a cheating drug. If you're a gun shooter, we know though that you can't use beta blockers. You know why?
Well, they're illegal, aren't they, for the Olympics?
But why? Why though? Why?
Because it slows down your heart rate, correct?
Yes.
Yeah.
So if you're shaky, you can literally hold your breath and you're just tight. When you're shooting, of course, an expert long gun shooter, which is not me, you hold your breath, you exhale, and then you really try to be motionless. Even the heart moving your body. So So beta blockers will slow your heart rate down. And I, as a mountain biker, which God knows I try my best to keep up with the good guys, I've tried using, so I always throw my own stuff in here, right? I don't want to sue myself. Tom, don't sue. Doctor, don't sue yourself.
Oh, boy.
I might sue myself. It's all for you, Ron. It's all I have to do. We get bored otherwise. Because all I do is say the same stuff over and over and over. So when I'm mountain biking about a year ago, I got to take Bystolic because my blood pressure's up, nitric oxide, I like it all. And when I'm cranking up that hill, my heart rate is maxed out. Yes, I like this question. I'm going to get better filling because my heart is going so fast that it's not, at a certain point, there's a point where there's a diminished return and your ejection fraction reduces if you have a non-healthy heart because you don't fill. So the restriction is certainly on filling for a diseased heart, not pumping.
Right.
So but here's the bottom line. So that's my answer to this guy. That's a great idea. But you know why it doesn't work? Because you put a limit on your maximal and submaximal threshold heart rates. This is exercise physiology. So here we are. And you feel exhausted and it puts a cap. So the limitation, I thought about this for this guy, the limitation on this, and I'm sure there's some data on this, the exercise physiology guys, nothing to do with steroids, is the limitation becomes in a non-diseased heart, it's heart rate. You want your heart rate to go up. As you get older, the heart rate goes down. But people can compensate for that. It just because the muscles compensate, they can still, but a great, highly trained endurance athlete, even older, of course, can tolerate very high heart rates maximally and submaximally. And the resting heart rates, I have patients that are biker, the road bike guys. Yeah. Some of them are really advanced guys. And, their heart rates are in the 40s. That's incredible. That's bradycardic tone. So their ejection fraction, their heart's so efficient that it's pumping. But if you say, and imagine like my heart rate's in the 50s now because I'm in good shape, good cardiac shape. Yep. So imagine you further lower your submaximal, maximal. You lower your submax and maximal heart rates with a beta blocker. I felt it going up those hills and those technical climbs. You feel exhausted. So you might be getting some increase in the cardiac output. Yeah. That's a benefit. But if your heart's normal and it's healthy, the overall effect is going to be a lower effect because you're going to feel there's a cap on your heart rate.
Right.
That's the last answer. I think what else was and then in the end of the day, for any of these men that have early coronary disease or early ejection fraction abnormalities, and it's called diastolic dysfunction, an ACE inhibitor, everyone. ACE inhibition is definitely the better medication. And then it goes into calcium channel blockers and then beta blockers. But this is all data, it's all generalized, but it really has to be, Ron, it has to be patient per patient.
Right.
So that's my spiel.
Now, can I just say that mountain and bike are two words that I don't believe should ever be together in the same sentence?
Ron, I got to get you on a mountain bike. Come on, Ron.
No. That's crazy. I mean, you got bumps and rocks and roots and
no. It's no joke. It's especially where you are, Ron. You got north of you got some good hills out there.
Oh, wouldn't you? I saw guys doing one. There's a hill around me called Blue Hill in Canton, Mass. It's a pretty popular spot in this part of the state. And they have a big mountain bike trail that goes around it. And I see these guys, I'm like, if you're out of your minds, It's
jumping. I know. Well, I tell you, Ron, the interval cardio, the high intensity interval cardio. Yeah. I mean, it's just brutal.
I'll do mine.
But it's a good high.
I'll do mine on a nice, comfy little machine with air conditioning. Got my little water there. Yeah, my music, and it's all.
You're still a musclehead, Ron. You're still just a musclehead.
Okay, so Swaminator is our all-star with questions for the doc. And here's a good one from the Swaminator. Rookie HGH question. I have no experience with this at all. Some TRT clinics offer HGH for quote-unquote anti-aging. All seems legit as it requires subcutaneous injections of products such as Semarelin. But in talking to a competitive bodybuilder at the gym, he says that those TRT products are only HGH enhancers, not the real thing. He said only AIDS and cancer patients can get the real stuff. or you have to get it on the black market from China. He said alpha-tropin and serotropen are real HGH and extremely expensive, up to $500 to $1,000 per month. Can you please share your thoughts on fake versus real HGH? And are either something that will add muscle, lose fat, and at what risk, if any?
You know, Ron, so everyone knows that I'm an expert in anabolic steroids and how it affects the heart and the kidneys and, the old school steroid use and stuff. This stuff, I mean, here's what I'll tell you about it. So Samorlin, this is new, right? This is out there now. Anti-aging places, that's Samorlin. It's pronounced Samorlin.
Yeah.
That's a growth hormone releasing hormone. That's an analog that so it's not that supposedly, if you read on it, is better because it's not going to have the carpal tunnel syndrome, the risk. It's not going to have the side effects because it's working it's kind of like Clomid is to testosterone. Like Clomid stimulates your own your endogenous testosterone, right? Yeah. And so this is a growth hormone releasing hormone. So it's an analog that stimulates it stimulates your own growth hormone to go up, and therefore it seems like in the end it seems reasonable to me, but Ron, I don't know. Yeah. So, but growth hormone is expensive. In the end of the day, this stuff is not as expensive. I research this stuff, and I see a lot of a lot of patients come in and all this stuff. A lot of patients come in. I'm not putting any of these clinics down. I got to try to be politically correct here. They go to these places all over the country and outside the country. They get what they want, and then they come to me to get hopefully not cleaned up and picked up the pieces when they have a heart attack or something. But the truth of the matter is that the places they're not focusing on the clinical medicine so much, but these guys are getting what they want. They want growth hormone. They want testosterone before they have low T, I guess. I mean, it's kind of really just steroid use, I guess, at low grade.
Well, I'm somewhat familiar with it. I looked into it years ago on my own because I didn't want to go through black market sources, and a friend of mine was using a place out of Florida. So I looked into it, and I saw, the website had full on, it was a menu. It was like a full page, top to bottom, probably 50, 60 different, all types of testosterone, all different esters. You could get DECA, you could get Winstraw, and crazy. Anything you want, growth hormone. It's just legal.
So I mean, Ron, there's no kidding around. I don't agree with that, Ron, because I mean, I've been doing this for so many years that living long enough, you're going to have a heart attack. So some of these medicines, I'm trying to really figure out the mechanisms, and there's enough doctors that understand. If you have low T from steroids, come on in. Yeah. You need testosterone. I mean, but you got to watch it with. You got to watch. You got to really understand. For every there's complications and side effects to everything. You got to come on, people. I mean, who's going to say there isn't? But it doesn't mean you don't do it. It means that if you do it, you just better beware and have the best expert advice around you and to monitor you. So this stuff, growth. So those are called growth hormone enhancers, Swaminator. You're right. And the data, we don't know if in the end, if you're just measuring IGF alpha. Yeah. Please, I don't spend all my time reading about growth hormone analogs and growth hormone. I spend my time more on the heart and the kidney and more about those things. And of course, diagnosing and treating men with TRT, obviously that need it, and we both agree, and we go forward. But this is stuff. It's going to be interesting. But I the last year or so, I'm hanging up. Well, I did an article. You'll see on my website about IGF alpha growth hormone with heart disease, and I did a lot of research. So I spent like probably 10 hours, so I didn't get slammed by people researching. So I better look like I know what I'm talking about. Yeah. This stuff, like the hard stuff. I mean, this is my day job, so that stuff, and I have to keep reading on that too. But I read about that. I did an article. If you go to my website, it's on there, and of course it reflexes to steroidology.com. Because that's where I did some writing for that guy, and my stuff's still there. They presented the article really well. So if you read the article. In the end of the day, if you have heart disease, modulating IGF alpha levels is important. But that's once you have heart disease. Yeah. And everyone's taking an apple with an orange. I mean, it's not. So before you have heart disease, these are people in heart failure and old people. But then if you look for the data, IGF alpha levels on the oldest people, it's better to have them low. I'm still trying to get my head around all that. I'm not one of these anti-aging, real PhD guys that's really studying like molecular mechanisms in a rat. Like these guys really know this stuff. I talk to them, and that's why my level is clinical. Blood pressure perfect, cholesterol perfect. I love metformin for most people. Certainly, someone who has pre-diabetes, it's directly going to save your life because we know the mechanisms. So that's all easy. That's all easy stuff. But you got to know what you're doing on that. But as far as living on growth hormone, it does burn some fat. It's synergistic with steroids, but carpal tunnel. It does call. It seems like guys do a lot of guys in the black market. They say, Doc, you know how we know? You know how we know if we have the right stuff? We take it. Yeah. Ron, you've heard it.
Of course.
That's like crazy. It's like, really? Oh, Doc, I know it's real. Well, how do you know it's real? Oh, because my hands, man. I can't feel my hands. Well, that's the dose I know. I just bring it right to the point that my hands go to sleep, and I know I'm all good.
And they're usually very happy, even though they're having, because then they know that it's $1,000 they just spent on a few kits or whatever is legitimate.
Come on, this is the best stuff. You can't make this stuff up. I mean, you're seeing it, I see it. So, but does it grow? It is true. And I call Dr. T, the doctor in Greece. It's like the Anabolic Doc in Greece. Like he's a pathologist. Like this guy knows all this stuff. He writes with Llewellyn and stuff. This guy's a smart guy. It definitely synergistically, when you put all the stuff in the melting pot together, it grows. It's you don't want it. I mean, so there's gonna be a fine line. Anti-aging, I don't know about anti-aging with that. I just don't know. No one knows.
Yeah.
So I call the guys, I used to years ago before I was learning all this stuff, I'd call up the guys at Sloan Kettering, hey guys, and right down the road at Dana-Farber, I would call these doctors and I would talk to them about different things. And I found out that they actually know stuff about IGF alpha because they're hematologists. They measure it for cancer. And one of the guys, it was at Dana-Farber or Sloan down in New York City. I had a patient with lymphoma. I've seen a few patients with lymphoma because people get lymphoma.
Yeah.
And the patient thought that it was because of his steroid use and growth hormone. So I called the guy down at Sloan, and he goes, Tom, we don't know. And he goes, but he did say one thing. He goes, I'll leave you on this, Tom. We got to go. We're all busy. He goes, you're increasing IGF alpha to super physiologic levels?
Yeah.
Well, that's a cancer marker. So it's insulin-like growth factor. So you're going to be growing, again, it's so common sense. You're growing tissue that's called cancer. That's uncontrolled cell growth is cancer.
Yeah. So
if you have a cancer in your small bowel or your colon or a melanoma, I know the bro science stuff. Watch for melanomas if you have them. But then people come back to me and they say, Doc, look at some of these bodybuilders and some of the older, I don't want to say names. I'm not even going to say names.
Yeah.
We all know the names. There's some 70-year-old actor bodybuilders that are still walking around, and we know they're on growth hormone for 20-something years. Well, that's not really a study because we could see that guy in the state.
And because one guy is doing okay.
One guy's still walking around.
That means it's safe for everybody.
And you know what someone said to me the other day? Someone goes, when I brought this up with my patient when they came in, and he goes, this is like a few months ago, and he goes, Doc, that guy's so rich. He's got to have clones.
I don't know what the technology status is on cloning right now.
Oh, it's good. You can clone your dog now in South Korea for 50 grand.
I know. I don't even want my dog cloned. But, what was I going to say about that? I don't know if you recall a bodybuilder named Dennis Newman from the early 90s.
Leukemia.
He had leukemia. And he was convinced, and he never had any evidence back then, but he was personally of the belief that his growth hormone use accelerated the leukemia, and that's what ended his career at basically, he was like 25 years old.
Is he still alive? Is he still around?
Oh, yeah, he's doing fine now. He's doing great, but he hasn't been he quit competitive bodybuilding many, many years ago.
He looked great, though. I saw him in person in the 80s.
No, he's my age, so he's 48. He turned pro in 93 or 94, so he would have been like 24, 25 years old. And then I think the leukemia, he came down to leukemia almost immediately after.
Oh, you know what? I was in Syracuse University 1994.
Yeah.
And I remember, I saw him then. He was on some guest posing thing, and he got sick right after.
Right. That's right.
He looked phenomenal, though. He did look phenomenal.
He was someone I always thought, potential. When people ask me, who do you think could have been really good if, whatever hadn't befallen him, and I always say Dennis Newman. He had a phenomenal physique, and he looked like Superman. He looked like a movie star facially too.
Good looking guy, yeah.
He was a big jacked Steve Reeves, basically.
Yeah, wow, it's crazy.
So Swaminator had a second part of the question. I saw on the forum where a very well-developed competitive bodybuilder is only on TRT and a very small dose at that, 5 milligrams per day, which I'm going to call BS on. Is there that big of a benefit doing daily injections over weekly that you can get away with using far fewer milligrams per week? 5 milligrams a day. So that's
I don't know. So I have guys do this.
5 milligrams a week? Come on now.
Well, I don't know. What's the guy put out, like 7 milligrams a day or 10? So if you look for, like, if you give a guy testosterone injections, esters, if we give 100, if we're giving 0.5, half a mil every week or every 5 days, so that's 100 milligrams every week. So if you divide it, it comes down to, so it's like, I have a guy that does do every day, I think it's 10. He gives, and he uses an insulin instrument. You know why he does it? He does it because this is a man who had some he had some heart disease early. He probably had the heart disease multifactorially. He has bad genetics. He used some steroids. He had bad cholesterol. He had everything lined up, and he had a stent placed. He's still alive, very young though. He was probably in his late 20s.
Wow.
And when he had the stent, just bad genetics.
Yeah.
And he used steroids. He accelerated it all. So he came in, and after the cardiologist, and he came in, and I went over everything, and he was still taking an aromatase inhibitor. And I go, sir, your HDL is in the single digits. That's not good. Yeah. And I said, and I went through his med list, and he said, oh, the docs, they didn't know about this, and I don't think he told them, actually, cardiology guys. But they did say, again, you're on testosterone. You probably shouldn't stop it completely, because after 10 years, like, you're going to need some testosterone, but we're going to give you statins, beta blockers, ACE inhibitors, all these drugs. And so he didn't tell them about it. And then I said to him, look, you have bad genetics. Your HDL is in the single digits. One of the reasons why, apart from your genetics, is the aromatase inhibitor.
Yeah. So
he goes, Doc, if I come off the aromatase inhibitor, I'm really worried my estrogen is going to go up, and I've always blocked it, and I feel bad. Like, he tells me, really, he gets flushing. He cries. I'm not kidding. He's very labile, crying. He's like crying, and his gynecomastia. And this is all stuff I talk about all the time. So I said, you know what, sir? I mean, we have to balance this with your life and your coronary disease. So we don't want to have you have another heart attack. So he goes, all right, Doc, here's the deal. Why don't we try this? This is over years how I learned this stuff. I said, you know what, sir? The only way we can modulate estrogen aromatization of testosterone is take smaller doses more frequently. Ron, this guy controlled his estrogen completely. He does do every day or every other day little teeny doses, maybe 10 milligrams, I swear to God. So when I read that, so the question is, the well-developed bodybuilder, I mean, we're never going to know, Ron, how much they're on TRT. I'm not going to say names mentioned, but it's all over the internet. A couple guys say they're natty. We're not going to go into who they are, what guys are out there. I think it's embarrassing. They still say they're natty. I mean, it's like every other man has come out. I mean, why would you embarrass? I mean, how can you even be, what I'm talking about. There's a couple.
I mean, you can, because they know that there's a certain segment of the population that's naive and gullible, where me and you, we can look at somebody and immediately I know an enhanced physique versus a non-enhanced physique. 99% of the time, I'm right.
It's insane. Is that that one freak that we've never seen, or maybe it's probably a freak with genetics and he doesn't use much. So just say that. Just say you don't use much. But don't say you don't. Anyway, that's always been, this has been going on since the 80s, Ron. You know, we're about the same age. It's a lying man's drug. Guys in the gym saying they're on steroids, and you go like, really? How come this buddy of mine just sold him all those steroids last week? But then it's always, he just quit. That was the last time. He never did any more. Yeah. So the question for that is, living on developed guy, living on small doses, is there a benefit? So there's no known benefit other than estrogen. So it looks like if you take small doses and you balance them out with the frequency of the injection, you probably definitely have a slower or an alteration in the aromatization.
Okay.
So that's a benefit. But then you have to balance it out versus being a pincushion. Mm-hmm. Like, don't some guys even if I give guys weekly doses, I have guys that tell me, Doc, I forget. After years and years, I just forget to. Don't you know that, Ron? People forget.
Yeah.
So who's gonna continually? There are a few guys that are very, very organized, very regiment, and they do it every day. But I just don't. I think the best is a small dose with a frequency about every 5 to 7 days.
So the second part of this question was, and you just talked about this gentleman, a patient of yours, using an insulin needle. So he's saying intramuscular injection versus subcutaneous. Now,
okay.
I always thought, and please correct me, that steroids had to be injected intramuscularly. I didn't know.
No, they don't have to be.
They don't have to be.
No. So I'll reference a doctor who's a very good doctor named John Chrysler.
Yeah.
Chrysler. You know, have you heard of him?
No.
He's an anti-aging doc. He's been out there for a long time. He's probably in his late 50s. I'm not going to go into his medical stuff and what he does and what he said, but he's very open. You could Google him. You could look at him. There's videos of John. He's a doctor. He's an anti-aging doctor. Mm-hmm. And who's standing up at his desk like I do my videos, going, "Hey, look, I do one every day. Yeah. I do these small," and he's showing to the camera like, and so there's arguments for this. There's no real clinical trials on any of this stuff. It's anecdotal, and it's man per man. Again, if intramuscular injections, it's designed intramuscularly. There's capillaries in the muscle. There's also capillaries in the fat.
Right.
So you can do intramuscular injections. When I see guys doing that, because I do have a lot of guys, I see what they do. They come into me. I hear the story. I've been doing this for 10 years or more. And I just see that when men do those sub-Q injections, I see a lot of cellulitis. They get skin infections. Wow. So cellulitis is a skin infection, but let's take it apart. It's an infection in the subcutaneous fat. So they're really dragging in bacteria from their own. It's not because of dirty needles or dirty skin. They're piercing and they're getting infections into their subdermal in the fat, and they get cellulitis. No one's dying, but it's a pain in the neck. You got to treat it. So
if you're using sterile procedure, though, I don't understand why they're getting bacteria introduced into cellulite. It's not.
There's no such thing as sterile procedure. When you want a sterile procedure, that's where you get betadine. You go into the operating room and you scrub the hell out of it, and they put this plastic on top of the skin. Even that's not sterile.
So the little alcohol wipe isn't.
Come on, Ron. You know what? I'm just telling you guys what it's just that stare. You're wiping, but it's what we do.
Yeah.
I don't know. I think there is a study where someone did injections without doing the alcohol swab wipe versus just putting the injection, and I don't know if there was a difference.
No difference.
It doesn't. Yeah, isn't that cool? This is our show, Ron. This is our show. But I'll tell you this. That you still have to follow conventions. You got to use the alcohol swab. Who the hell's not going to?
No.
I mean, at least if there's frank dirt there. If you have true grease and dirt there, at least you can get the grease off.
I've seen videos of guys coming out of the gym. I won't say his name. Through his workout pants.
Yeah.
Through the pants into his thigh.
I know this person.
Sweaty thigh. And that's
did not get an infection because the body's incredible. But the getting down to the sub-Q versus the IM, the men that I do see these small injections more frequently to kind of modulate the doses more, you know what? They're doing it intermuscularly because in the thigh, if you're really lean, Ron, your skin is about that freaking thick.
Right.
Because the thigh is, the side of the thigh, it's all, just lift up the skin or keep it or lift it up and you can go underneath that sub-Q. Or if you just go right, an insulin syringe with a small 29 gauge needle, that goes right into the muscle. You know, years ago, I said to the guy, you know, here I am, me, years ago, I was ignorant. So I go, oh, so you're doing sub-Q injections with that? Is that what you're doing? He goes, no, doc. I'm doing, we're going into, you can't do glute injections with an insulin syringe, but you can do IM injections into your thigh.
Yeah.
Because you're going right through the skin. The skin is super thin.
Right.
So I don't know. There's really no difference with, I don't know of any difference with sub-Q versus IM on that level.
Okay. I had a couple questions. You could probably make whole shows out of this, but just for a minute, drugs aside, do you have patients or have you seen patients that just being a certain size, carrying a certain amount of mass above and beyond what an average male would carry, is that in itself a big cardiac risk?
Ron, yes, of course. Big dogs die. And it's all related to this. So big dogs get, when a man is big, he proportionally gets too big. It's mean, you know, he's overweight. That relates to elevated blood pressure, bad cholesterol, pre-diabetes, and diabetes. Now if you're fat where in the belly. Yeah. But if you're just a big man, not necessarily. I mean, but who's big and, you know, so a big farm boy? I mean, a big farm guy who's just like, but here's the truth, Ron. It's a great question. The big dogs and big people don't live as long as little. Now there is, apart from that, that's cardiac. That's all related to coronary disease and heart failure. Right. It's all the same stuff I talk about. So you want to be a little dog. And at the end of the day, but I'm using medicines to preempt and to block those effects. But your question really leads up to, what about those people that are called the healthy fat? So there are people that in middle age and into later middle age, like 60s and 70s, they're heavy, but they have good vital signs. They don't have diabetes. They're not hypertensive. Their cholesterol is not bad. They have good genetic. I have a bunch of patients. I won't even think of who they are for breaking any laws. They're heavy. And if you look at their labs, we both look at the labs together. These are women too. And we go, oh my God, it's crazy. And she just has great genetics. Wow. But you know what happens though to the big people? For sure, their knees wear out. I mean, they get osteoarthritis. That's wear and tear though, right? Because they're just, imagine the weight on the hips and the knees if you're heavy. So that's just sheer mechanical. Right. But so the truth is, Ron, you definitely want, that's why I suffer myself with, I try to be as small as I can, because I just know that if you want to live a long life, you need to be as lean and mean as possible. 110, that's a long life, doctor. I'm trying to do the best I can, Ron. You know, I have a Shih Tzu. She'll be 16 in October, and she's still kicking. She's 10 pounds, no signs of slowing down. So my other question. Come on, that's a small. You see my dog the other night, Ron? You saw my dog, right? I did, yeah. That's a Shih Tzu. That's a poodle. A Shih Tzu poodle. Okay. That's Scotty. Scotty's famous. Well, a regular sized poodle is not that small. No, I have so you see the other video I did? That's Victor with a big puff. Yeah. He's a standard poodle. He's 80 pounds. Ooh. He's a big boy. Yeah. But so Scotty's a little guy. So and if you're gambling in Vegas, we don't want to say it with my girlfriend hearing this. Yeah. Scotty's going to live a longer life. Yeah. I mean, than Big Vic. But you know what? You know, we'll give beta blockers to Vic. We'll give him ACE inhibitor. You would certainly have probably one of the healthiest dogs around. I have no doubt of that. We'll see. And the other question I had, and again, this is probably something I don't know if you want to go into more detail at a later date, but because people have been talking about certain pro making a comeback, and he's over 50 years old. And I don't want to, he's a good guy. I'm not going to throw his name out there, but is it any more hazardous to the health of an older man? So if I'm 50 years old, is it more dangerous for me to use steroids in the way a bodybuilder uses them in these super physiological doses than it would be if I'm a 25-year-old man, all else being equal? Ron, that's a great question. And the truth of the matter is the older man already has disease already.
Hmm. He will have it.
He does.
He's going to, just because he's 50.
He has to.
Hmm.
If you're gambling in Vegas, he's going to have. So that's why these young kids are kind of like, show me the bodies. Well, we have bodies now.
Yeah.
But I mean, that's why you're young. You have no disease. So your body could take the beating. But if you're older, Ron, I've seen countless numbers of guys that are between 50 and 70 that started steroids. That's a good question, Ron. You actually asked a great question.
Okay.
And they definitely did bad quick because because they had plaque in the artery. And when they did, let's just say I'm just thinking of one individual, but I'll mix them into about 10. So 50-something-year-old man, he has hypertension. He already had plaque in the artery, but he didn't know it. And then he does 500 milligrams of test and 400 of equipoise and does some Anavar. And he does it for like 18 months. I mean, he had a huge heart attack.
Wow.
I mean, so now there's many men. So he was significantly hypertensive on that regimen. Yeah. He was on and off the orals, but he stayed on the test and the equipoise pretty much the whole time, on and off. He just modulated the doses.
Right.
He went down to about 200 of test, maybe 100 he switched over to DECA, but he always kind of cruised on that. He was always hypertensive. I mean, he didn't watch his weight and his diet. He was hypertensive. His cholesterol was always bad from even being a young man. And the only thing that was good on him, which is good on most of these men, he wasn't near diabetic or pre-diabetic because he was lean as crap. But hypertension and bad cholesterol on top of a 50-something-year-old man who already had subclinical hidden plaque. So this guy, he had that, like he had plaque that was like these two right here, like these, and it just and then I've seen this on men, and then the heart did enlarge. He had LVH, and then in the end of the day, he survived the heart attack, and he's just on TRT. I mean,
he's doing fine now.
He's doing fine.
Oh, great.
Yeah, but he knew there's no free lunch, Ron. If you're gonna, I mean, young guys can do whatever. Young guys, of course, because they have no disease.
Right.
So the question is to me it's a question that's easy to answer. If you're older, you have disease already, because what 50-something-year-old guy is not going to have plaque in the artery? I read this morning some famous comic just had a huge heart attack. He's a heavy. I don't think he's a steroid user. He's just kind of a heavy. Men actually have heart attacks without steroids.
Well, obviously.
and if you do steroids, it definitely progresses the plaque. I mean, on that level, we're fighting some of the wisdom of some of the studies saying that TRT causes plaque progression. We don't know. Some men, even a little. That's the Fed came down 3 years ago and they said TRT can cause heart attack, stroke, and death. Ron, that's just TRT, not steroid. So the truth is, it's the data for these studies is inconclusive. Thank God. But I will still tell patients, if you're a man and you have bad genetics and you have plaque in your artery, you're going to have a heart attack someday anyway. I mean, for sure anyway. Why don't you, without testosterone, without steroids, why wouldn't you modulate and try to prevent that? So we have ways to do it. But steroids lower HDL, they can increase LDL and hypertension. And and then they can increase red blood cells. And there is data that steroids, because of modulation of the hormones, may cause a hypercoagulable state.
Thick blood.
Thickened blood is, but it definitely thickens blood. But most guys with thickened blood, knocking on wood, they don't have heart attacks and strokes. But if you put all these pieces together, Ron, with this man who's susceptible, you speed up, you accelerate coronary disease. That's what we're seeing, in my opinion.
Okay. So the conclusive answer is yes, it's definitely more dangerous, generally speaking, for an older guy to use steroids.
Because the older guy is going to have already disease.
Right. Okay. Final question from Fabian Gym Food, which I didn't get to last time, but I made sure we got it this time. What is your opinion, doctor, of leaf extract for metabolism boost and against hypothyrosis? My TSH value is high, but within the normal range. Leaf extract.
All right, I didn't even get to research this, so I'm going to wing it off top of my brain. All right, so leaf, I don't know what that is. I don't know this stuff. I'm more of a conventional doc.
Right.
I stick within, I color within, medicines and steroids. I know steroids, testosterone. So, but let's talk about what he's saying, though. Let's dissect the sentence here. Metabolism boost, and then thyroid. So hypothyroid, it's hypothyroid state.
Yeah.
That's hypothyroidism. I know about this. And then his TSH levels are high within normal range. So let's talk about hypothyroidism.
Yeah.
The most common type of hypothyroidism is called Hashimoto's thyroiditis. It's 80 of 10 people in the room, there'll be 8 will be women. So it's more women than men. This is immunological data. We don't understand fully why. So, and it's the signs and symptoms for hypothyroidism are, as you can imagine, malaise and fatigue, energy levels, weight gain, right? And then it's like, bowel movement changes, sexual issues, depression. It's all these kind of subjective. But then every doctor, when we screen blood, we do a TSH. So that's a thyroid stimulating hormone out of the anterior pituitary, and that's the standard of care. So you check that, and then it's an opposite. That's a pituitary stimulator. So the thyroid's in the neck. So if your thyroid levels, thyroxine levels, if they go low, your brain is going to detect it, and so your TSH goes high. So that's what he's saying. This case, what he has is called subclinical hypothyroidism. Subclinical means your TSH is under 4.5.
Okay.
So the range is 0.5 to 4.5. This is just standard. This is standard general practitioner internal medicine. It's just endocrinology, right? It's endocrinology. So, and I don't want to be an expert in thyroid, but I've learned a lot because I'm a concierge general practitioner. So I have a lot of people, more women than men, that have hypothyroidism. And then at the end of the day, they get diagnosed because of the TSH goes high. The doctor says, oh, you have Hashimoto's. You could check antibodies, and you could check a real panel. You could look for, let's see, TSH, free T4, reverse T3, free T3, free T4. There you go. That's a full panel that you could check. And then those are like the tea leaves. Most doctors prescribe Synthroid, levothyroxine, that's generic, or Armour thyroid. But, a lot of conventional doctors, they don't like Armour, desiccated combinations. And they probably should, because combinations of T4 and T3 are probably better. So, Ron, but I don't get really, I'm a cardiac steroid guy. So the end for his question, metabolism boost against hypothyroidism, and his TSHs are high, but they're still normal. So he has subclinical hypothyroidism, and does this leaf? I almost want to say olive leaf or olive. Is that a natural derivative supplement that acts like a thyroid stimulator?
Yeah, I'm guessing that's what it must do.
Or does it convert into like a desiccated thyroid, like to a T3 or T4? And the truth is, it might. I just don't know. So you have to go see it. There are some endocrine experts that are teasing out now that they're experts in thyroid. So if you go to see an endocrinologist, you really want to ask them, do you really understand the thyroid? Are you ready to work with me? And I really want an explanation, and I want to try if he does have upper limit normal TSH. Is a physician willing to give small doses of either levothyroxine, like these are like 25 microgram doses. You know, they're small,
Yeah.
25, 50, and then or combinations of T4 and T3, or desiccated armor thyroid.
But
So,
I guess my
and
question
it
would be
can really help.
why is he concerned if he's not hypothyroid? I'm not even sure
So,
why he's concerned.
so here's the thing. So he may have a condition called subclinical. If your TSH is over 2.25 to 4.5, again, we're splitting hairs here, but that's what I do for a living. Well, that's why people love to see me. I love these. If I tell people I don't know, but here's what I know. This is a lot of doctors are going to say, look, your TSH is under 5. Get out of here.
Yeah.
And some people are going to say, you know what, doctor, if you read the data, I mean, the internet's out there now. If you read it, you'll see that some people actually can start treating their thyroid between 2.5 and 4.5 and 5. It's called subclinical.
Oh, lost you there. Doctor is frozen. Doctor is frozen.
It's true.
Oh, there.
I agree. I don't treat thyroids.
Right. Okay. Well,
I don't really. I mean, I don't know. I mean, so this.
Yeah. Okay. Well, we're starting to have some technical difficulties. So.
Oh, I see that. I see that, Ron.
Now, actually, they can only see me. Oh, there you are again. Well, I'm going to take this opportunity to close the show out before things go any more haywire. So, I want to thank you, Dr. O'Connor, for once again giving us Ask the Anabolic Doc. Please visit his websites, anabolicdoc.com and metabolicdoc.com, and be sure to get this America on Steroids, A Time to Heal. Excellent read. Just finished it myself a few days ago. Can't recommend it highly enough.
Thank you, Ron.
Thank you, Doctor. As always, gems you're throwing out here. Good stuff. You're doing good work here. God's work, as I like to say.
I do appreciate it, Ron. It's as long as people enjoy it and we're helping people to learn about their bodies and their true health, it's what I'm here for.
Thank you, Doctor. For Ron Harris, this has been Dr. Thomas O'Connor with Ask the Anabolic Doc. Thanks for watching.